Okay, before we start talking about this thrombolytics, let's also go back to cilostazol and dipyridamole. So the mechanism, what are these guys doing? Well, cilostazol or pyridamole, they increase, first they cause vasodilation, and they inhibit platelet aggregation. Well, all of this is done due to the fact that you have increased in cyclic AMP. How did you increase the cyclic AMP? Well, let's write it here. So cyclic AMP normally will get destroyed and forms the AMP, and it gets destroyed by PDE3, prostaglandin or PDE3. So you inhibit, so these things, they block this phosphodiesterase. So cilostazol and these things, they inhibit here, which leads to increase in cyclic AMP, and that increased cyclic AMP led to vasodilation and inhibit the platelet aggregation. And that's the mechanism of action of antiphosphodiesterase inhibitors. Moving on to the next thing, what do we have here? We have the thrombolytics. In thrombolytics, we have Alteplase, which is TPA, Reteplase, which is RPA, and Tenecteplase, which is TNK-TPA. Okay, so what's the mechanism of this thing? These all thrombolytics. They directly or indirectly aid in conversion of plasminogen to plasmin. And this, which cleaves, now plasmin cleaves thrombin and fibrin, which causes increase in PT, increase in PTD, no change in platelet count. Okay. What is the clinical use of these things? You can give them in an early MI, early ischemic strokes, direct thrombolysis of high-risk PE, adverse effects, bleeding, because you have cleaved the thrombin leads to bleeding. Contraindication in this patient with active bleeding, history of intracranial bleeding, recent surgeries, known bleeding diathesis, or severe hypertension. Non-specific reversal with, very important, you can reverse them, but not specifically with antifibrinolytics, which is aminocaproic acid or tranexamic acid. What's the mechanism behind this? Again, you have the same sort of thing, that you have the plasminogen, right, that gets converted into plasmin by the help of these TPA. This thing is inhibited by aminocaproic acid and tranexaminic acid, so you can't make plasmin. So that's the way it works. Platelet transfusion, the other adverse effects, factor corrections like cryoprecipitated FFPs and PCC. So the reversal can be done by either this, or you can just transfuse the whole platelet transfusion, or give factor correction, or cryoprecipitate FFP and PCC. Okay, so yeah, that's pretty much all we have for plasmin. So here they only mentioned that plasmin is going to cleave thrombin, but plasmin is not just doing that. Plasmin is also causing when it cleaves the thrombin, it also causes the formation of, when it cleaves the fibrin, it formation of D dimers, increase in D dimers. Okay, but you can inhibit all of that by giving antifibrinolytics, platelet transfusion factor corrections. So that's all for the thrombolytics.